Good evening and good morning, I believe.
Mhm.
There are people from all parts of the
Good afternoon, all. Welcome to the Live Study Group's second webinar for the year, in which we have collaborated with Lexicon India. Thank you for taking the time to join us today. This session is scheduled to begin at 9:30 p.m. IST, as well as 12 p.m. AST and 4 p.m. GMT. A feedback form link will be sent in an invitation and will be resent towards the end of our session on the Zoom and YouTube chats. Those who fill out this form will be getting certificates of participation. Please note that this session will be recorded for archive purposes. Please bear with us as we will begin shortly.
इसको बंद करो। वीडियो मैंने हटा दिया। हाँ, अभी ठीक है।
Good afternoon, all. Welcome to the Live Study Group's second webinar for the year, in which we have collaborated with Lexicon India. Thank you for taking your time to join us today. The session is scheduled to begin at 9:30 p.m. IST, 12 p.m. AST, and 4 p.m. GMT. A feedback form was sent in your invitation link and will be resent towards the end of our session on Zoom and YouTube. Those who fill out this form will be given certificates of participation. Please note that this session will be recorded for archive purposes, and please bear with us as we will begin shortly. Good afternoon, all. Once again, welcome to the Live Study Group's second webinar for the year, in which we collaborated with Lexicon India. Thank you for taking your time to join us today. The session is scheduled to begin at 9:30 p.m. IST, as well as 12 p.m. AST and 4 p.m. GMT. A feedback form link was sent in your invitation and will be resent towards the end of our session on Zoom and YouTube. Those who fill out this form will be getting certificates of participation. Please note that our session will be recorded for archive purposes, and please bear with us as we will be starting shortly.
Sir, can we start?
Okay. Shall we start?
So, yes, just okay. Good day to all. I hope you're all doing well despite the new pertinent challenges that we're all facing for substantive time. My name is Tarashi Bhattacharya and I'm your co-host for this evening. It is my first and foremost duty on behalf of my team members to warmly welcome you all to this insightful session. Thank you for joining the Live Study Group and Lexicon collaboration webinar featuring Dr. Shekhar Kashyap on COVID-19 in India and elsewhere, a much needed update on what's left to know. The Life Study Group is a team under the Students Against COVID movement, or a collection of interested, enthusiastic students willing to learn and help others progress and enhance their knowledge amidst this global crisis. The Life Study Group consists of two sub-themes. Firstly, the General Life Study Group, where we promote education via various means like webinars, study flashcards, case discussions, and much more. And secondly, Mental Health and Student Support Team, where we provide a safe space for students to motivate and encourage others. Do feel free to be a part of SAC and by extension, the Life Study Group. More details will follow at the end. Lexicon is an online medical magazine that blog that aims to empower medical fraternity in using their knowledge and make a difference via literature. An initiative of SRB Educational Trust, it is a quarterly magazine featuring a broad variety of content via its articles, initiatives, photography, and artwork. With a legacy of 8 plus years, 34 editions, and giving a platform to over 100 individuals to share their work till date, we are working towards being a go to and a friendly option for the medical fraternity to showcase their talents. In case you have any questions throughout the webinar, go ahead and pop them in the chat box and I'll be responding to them in due time. Now, coming to our speaker. I'm privileged to invite our guest speaker, Professor Dr. Shekhar Kashyap, who is a clinician, interventional cardiologist, and an academic with more than 40 years of experience. He has been Professor of Cardiology and Medicine at the Universities of Pune, Delhi, and Rajiv Gandhi University of Health Sciences, Bangalore, Karnataka. Dr. Kashyap is a graduate of the prestigious Armed Forces Medical College, Pune. He did his specialization in cardiology at AIMS, New Delhi, and training in interventional cardiology at University of Rouen, France. A former head of the Department of Cardiology at Research and Referral Hospital, Army, New Delhi, and head of Department of Cardiology at the Command Hospital, Air Force, Bangalore. Dr. Kashyap was cardiologist to the President of India, Mr. K.R. Narayanan. He has worked extensively among the native highlanders in the upper reaches of Ladakh, carrying out original work in the field of high altitude cardiovascular physiology and chronic mountain sickness. A medical anthropologist by disposition, Dr. Kashyap has worked among the tribal populations of Northeast. Dr. Kashyap is also engaged in establishing and overseeing the functioning of St. Jude India Child Care Delhi Center, a non-profit organization which provides logistical support to below poverty line childhood cancer patients. His current preoccupation, apart from preventive, clinical, and interventional cardiology, is to help propagate easily implementable evidence-based therapeutic and behavioral interventions at household levels. These include tobacco, alcohol, and nutrition-related lifestyle modifications at the intersection of prevention of cardiovascular diseases, diabetes, cancer, and also their role in preventing COVID-19. Tonight, Dr. Kashyap will be briefing us about COVID-19 complications, the triad of COVID-19 tobacco CVS diseases, and home quarantine along with treatments. Without further ado, I now invite Dr. Kashyap to take the lead.
Thank you, Tarushi, for that generous introduction. And good evening to all those who are in the Eastern Hemisphere. Good morning to those who are in the West. And namaste to everyone else. Okay. So I'll now share my screen, share screen. Is my first slide visible?
No, sir, not yet.
Share. Is it
Yeah,
visible?
yes, we can see it now.
Okay. From time to time, I may ask for tech help. Who's my wife? I've asked her to be around. Okay. So I would be talking about COVID-19 and closely related issues of cardiometabolic health, cardiovascular diseases, tobacco, and last but not the least, and another satellite epidemic or pandemic of misinformation, that is infodemic. So I'll take you through in stages through all these. And what I will not touch is a hospital-based treatment, vaccines, because they require threadbare discussion at some other forum. So I'll be talking about COVID-19 as it intersects with cardiometabolic health, tobacco, and the misinformation campaign. As you all know, COVID-19 is coronavirus disease 19, to distinguish it from original SARS, which was described in 2003. And this originated in Wuhan region of China in last week of December, somewhere in December. And it was declared a pandemic by the World Health Organization in March 2020. It soon spread far and wide. As the definition of pandemic goes, it is in more than one country across many continents, and there's hardly any region of the globe which is not affected. And as late as on 10th June, I have updated this data. So almost 170 million confirmed cases and 3.7 million deaths worldwide, out of which India has had its share. The first wave was not so troublesome, but the second wave was bad. And we've had 29 million cases so far and 360, more than 360,000 deaths up till now. So that's huge. I'll juxtapose these figures. They're, of course, terrifying. But if you compare with tobacco, we'll see how they contextualize and how they interact and intersect with tobacco-related mortality and morbidity. To just summarize about COVID-19, it's just another respiratory virus, although it's a new virus. Vast majority remain asymptomatic or minimally symptomatic. Only about 14 to 15% have clinical disease, out of which 13% or so, 14% or so have mild illness. Another 1 to 2% have severe illness, and only 1 to 2% end up fatally. So as you can see on this axis, you have maximum health, asymptomatic person, uninfected, has a minimum health, the severe, the diseased person. So stage 1 is asymptomatic or minimally symptomatic. In stage 2, you have clinical illness, which could be constitutional symptoms, fever, loss of smell and taste, and other constitutional symptoms, or it may go on to develop pneumonia. In stage 3, those who develop severe clinical illness, either it could be adult respiratory distress syndrome or cytokine storm with multi-organ failure or specific complication of some organ system like myocarditis. Those who recover from this, we call them in stage 4, they recover to variable levels of their preclinical illness levels. Most of them remain debilitated for quite some time, and which is called long COVID syndrome. Some of them, of course, unfortunately terminate fatally. As you can see, the viral load, which is utilized in it is when you see RT-PCR test, the CT values, which is an indication of viral loads. Higher the value, lower the load, it's inversely proportional. The viral load does not have anything to do with degree of clinical sickness. As you can see, in pre-symptomatic stage, the viral load is more and it gradually comes down. But in some vulnerable patients, we'll see who they are. It generates a hyperinflammatory response. They go on to develop severe clinical illness. In some of them, it can result in cytokine storm. And by this stage, the viral load is almost not there, but it has unleashed a cascade of events which results in cytokine storm or multi-organ failure or specific organ failures like lung involvement or myocarditis or even brain involvement. So as you can see, the acute complications of COVID-19, apart from well-known complication or involvement of respiratory system, can involve almost any symptoms, right from neuropsychiatric symptoms to cerebrovascular accident, encephalopathy, delirium. In respiratory system, of course, pneumonia and ARDS is well known. Cardiovascular system, I'll be talking in greater detail little later. It can also induce coagulopathy and induce thrombotic events across vascular bed in any organ. It can result in acute kidney injury, resulting in variable degrees of renal failure necessitating dialysis. It can also involve gastrointestinal tract and hepatobiliary system. It can cause rhabdomyolysis by involving skeletal muscles, and in skin, it can cause urticarial or maculopapular rash or livedo reticularis. Sorry, livedo reticularis. Those who recover what is called long COVID syndrome or post COVID syndrome, or colloquially also called brain fog, etc., you have various symptoms like neurocognitive deficits, mood changes, depression, chronic fatigue, which is known in the aftermath of any viral symptom illness, is particularly pronounced with COVID-19 in some patients and can also induce sleep disorders. It can result in other symptoms also. The aftermath, the patients can be left with residual renal damage, liver dysfunction, or muscle wasting, weakness, deconditioning of effort tolerance, and it can also lead to hair loss in some patients. So extrapulmonary complications of COVID-19, it can involve cardiovascular system, as we've discussed. All this is just shown pictorially, which we've already described. I want to emphasize about comorbidities. As this slide shows, that the data from the US is there with us, that almost two-thirds of the patient had one of these comorbid conditions called cardiometabolic risk factors, or collectively called metabolic syndrome. Almost one-third were obese, almost one-fifth had diabetes, hypertension, one-fourth had hypertension or heart failure. And if you combine all these cardiometabolic risk factors, close to two-thirds of all patients who required hospitalization had these comorbidities. And also, the mortality was highest in those countries where obesity is more prevalent. These include US, UK, and the Flanders region of Netherlands. And conversely, the lowest mortality was seen in lean countries like Vietnam. So there is something common, which we shall soon discuss, which makes a metabolically deranged individual more vulnerable to COVID-19, not only COVID-19 infection, but once that person is infected, to develop more severe illness and more high rates of complications and higher case fatality ratio. So this, as you can see in this slide, I've tried to summarize the parallels between metabolic syndrome and diabetes on one hand and COVID-19 on the other hand. You see, at the cellular and subcellular level, the pathways are similar. It leads to activation of angiotensin converting enzyme, which is also the receptor for coronavirus to enter into the pneumocytes. And in diabetes, you have hyperglycemia, hypertension, which leads to involvement of cardiovascular system, Whereas viral infection initiates inflammatory response and multi-organ damage like myocarditis and heart attacks due to various reasons, pathogenic mechanisms like increased coagulopathy, arrhythmias, etc. In metabolic syndrome, you have chronic inflammation and reduced inflammatory threshold. The same phenomenon is seen in a much more severe form in the form of cytokine storm in COVID-19 infection. Cytokine storms activates coagulation system and cause excessive clotting, which is also seen in atherosclerotic patients of diabetes mellitus. Chronic inflammation leads to poor glycemic control and also involves skeletal muscle and causes rhabdomyolysis. Similarly, COVID-19 causes muscle hypoxia, inflammation, electrolyte disturbances, and also can also cause rhabdomyolysis. So as you can see that from brain to all the organs, the pathogenetic mechanisms overlap. And that is the reason why those who have diabetes and hypertension, it's not because they're merely because they're elevated blood sugar or blood pressure. It is the underlying metabolic substrate which makes them more vulnerable to COVID-19. Now, the long-lasting effects of COVID-19 are conversely, those who have recovered from COVID-19 can develop features of metabolic syndrome in the form of impaired glucose tolerance or smoldering inflammation, which can result in multiple organ failures. It can also result in stroke, cardiovascular involvement in peripheral vascular bed, heart attacks, etc. It can also lead to pancreatic involvement, resulting in diabetes as a consequence of pancreatic failure. I'll spend little more time on the cardiovascular system and COVID-19 infection. As you can see on the left hand side of this slide, the lung involvement is fairly well known. We've already touched upon it, and it's described very well by the lay press also that majority of the patients develop lung involvement in the form of acute viral pneumonia, which can go on to develop ARDS necessitating mechanical ventilation. However, there's a subset of patients who develop cytokine storm, which involves multiple organ systems and can develop vasoplegia, a kind of shock where characterized by low blood pressure, which doesn't respond easily to volume replacement or vasopressors. However, myocarditis is close third and in some series, the second leading cause of death after lung involvement. And it can occur either due to garden variety of heart attacks, which is due to thrombosis of coronary arteries or plaque rupture. It can also result in myocarditis, direct involvement of myocardium in inflammatory cascade of events. It can lead to arrhythmias, which can result in sudden death, not only during acute clinical illness. Some patients during their second or third week after having recovered from this illness can have sudden death. In fact, many patients, elderly patients whom I had known, who came home and they had sudden death at home because of myocarditis. When should you suspect myocarditis? When a patient has fatigue which is excessive. Patient has recovered, there is no fever, but the fatigue is out of proportion to clinical findings. When you have tachycardia out of proportion or bradycardia sometimes, these are the patients you should suspect myocarditis. After all, skeletal muscle and the myocardium both are striated muscles. So any virus which affects skeletal muscles and causes fatigue is likely to cause myocarditis. As you can see here, the risk factors are same for COVID-19 and cardiovascular disease, de novo cardiovascular disease, and the complications of cardiovascular complication due to COVID-19 disease is it can be part of cytokine storm and systemic inflammation, where myocarditis or cardiac failure is part of multi-organ system involvement due to COVID-19. It can be heart attack in isolation due to thrombotic event. It can be result in heart failure, where ejection fraction drops because of myocarditis. Myocarditis can lead to arrhythmias, or arrhythmias can occur de novo and cause sudden death. Myocardial injury can take place in the form of stress cardiomyopathy, and cardiac arrest can result in sudden death. I want to touch upon cardiotoxicity, not of COVID 19 alone. A rampant treatment with medicines which are not evidence based can also result in cardiac involvement and death. Steroids have been misused in India on a very large scale in minimally symptomatic persons, patients from day one, in very high doses for long durations and at inappropriate time in the course of disease. Steroid therapy can result not only in uh, poor control of hypertension or development of hypertension de novo, but they can also cause arrhythmias due to hypokalemia because anybody who gets pharmacological doses of steroids loses potassium in urine. So these are the they can hydroxychloroquine and chloroquine have been used without any evidence. They hydroxychloroquine, chloroquine, azithromycin, they all cause an ECG abnormality called long QT syndrome, which makes one vulnerable to sudden death. So that one should be aware that unnecessary treatment can also be troublesome. After all, we give medicines. All medicines have some risks, but we give medicine or some form of treatment when the likely benefits outweigh the risks. But if there are no benefits, as seen in trials, or there are no guidelines to support their use, we are exposing patients to unnecessary harm because of the risk of these medicines. So, to recapitulate, COVID 19 involvement can cause myocardial involvement in multiple ways. It can be direct myocardial involvement during the initial phases, which is not that common, the viral replication stage. Later, it can be due to immune response to virus as part of a cytokine storm or systemic inflammatory response. There can be stress cardiomyopathy, or there can be thrombi in microcirculation, which can lead to diffuse myocardial dysfunction. Coronary rupture can cause myocardial infarction. I'll touch on tobacco use and COVID 19 infection. As we gave you data from India, that close to 360,000 deaths have taken place. But every year, tobacco kills far more number of people due to tobacco-related mortality, and this problem has been compounded because of their interaction. Tobacco makes COVID makes patients smokers and tobacco chewers more vulnerable to COVID-19 infection, its clinical illness, severe forms of clinical illness, and fatality. Here, I may like to point out that in the initial phases of this pandemic, the tobacco industry surreptitiously got many articles published not only in the lay press but also in academic peer reviewed journals claiming that tobacco use gives protection against COVID 19. Preposterous as it may sound, it was readily accepted by many journals, these publications. But good news is that recently most of those publications have been retracted. And on this 31st of May, this past past fortnight, World Health Organization Director General Dr. Tedros laid all these controversies to rest by declaring that tobacco increases risk of contracting infection, severe disease, death from COVID 19 by almost 50%. And nicotine, the main addictive substance in tobacco, shares it increases the levels of angiotensin converting to enzyme, which promotes attachment of coronavirus to the tissues. So we'll see in this pictorial form how COVID 19 activates nicotine activates angiotensin converting to enzyme, which is the receptor for COVID 19 attachment to pneumocytes. Now, in a smoker, you can see how all the defense mechanisms are compromised. Normal airways have a very effective mucociliary clearance. The cilia are like horsetail, they beat in unison in a very rhythmic manner, aided by surface immunity and secretions, bronchial secretions. They trap all particles, foreign particles, pathogens, and clear them mechanically and immunologically. However, in smoker, as you can see, these are all not only damaged, but they are all in great disharmony. Secretions are excessive. They get the airways are locked with them. The ciliary motion is all haywire, and lack of surface immunity makes them more vulnerable to all kinds of pathogens, including COVID-19. They have increased permeability because of uh, inflammatory response. They have more angiotensin converting enzyme 2, which is a receptor for COVID-19 attachment, and hyperinflammation causes a lot of secretions, so it leads to spread of the viral particles not only through the blood circulation but also through the airways. Now, to contextualize COVID-19 among tobacco users, COVID-19 has killed 360,000 in year and a half in India. But you can see that tobacco kills more than 1 million persons every year in India. This is a WHO fact sheet about India. And contrary to popular belief, tobacco kills far more people due to cardiovascular disease deaths as compared to cancer. You can see only 10%. I'm not minimizing the importance of cancers among smokers, but cardiovascular diseases are far more, 50%, almost 50%. And these deaths take place at the prime of a person's life, young deaths, premature mortality. Tobacco is the leading cause of premature mortality. Not only that, the cardiovascular deaths, which are the leading cause of mortality in India also, 16% of all cardiovascular deaths are due to tobacco. So, tobacco related deaths, 50% are due to cardiovascular diseases. And of all cardiovascular deaths, 16% are due to tobacco. So, tobacco control is essential for preventing and controlling deaths and disabilities, not only due to COVID, cardiovascular disease, but also COVID, as we've seen, because it makes not due to multiple mechanisms. The smokers have a habit of palling around, hand to mouth contact is increased whether you smoke or chew tobacco, and then chewing tobacco makes people more, they generate more saliva, then they have to spit it, thereby increasing infection, spreading infection. And as you can see, the nicotine on cardiovascular system kills through various ways. Nicotine is a direct spasm, can cause spasm of the coronary arteries. It increases sympathetic activity, increasing heart rate and blood pressure, increasing myocardial oxygen demand. It can cause arrhythmias, which can result in sudden death. It is also prothrombotic. It increases thrombus formation, which leads to normal garden variety of heart attacks. It also causes dyslipidemia, systemic hypertension, and is a pro-inflammatory. Not only that, what I've mentioned in the separate box, that nicotine blunts effects of all forms of treatment. You see, cardiovascular coronary artery bypass surgery involves grafting of diseased arteries. The grafts have a tendency to occlude on those patients who continue to smoke. Similarly, those who undergo angioplasty with stent implantation, the smokers have very high incidence of acute stent thrombosis, and also in-stent restenosis at a later stage. The medical treatment which is given to both the subsets, whether they undergo surgery or medical percutaneous intervention, or treated as a standalone measure, the beneficial effects of all classes of medicines is blunted by consumption of tobacco. Beta blockers, their effect is blunted. Antiplatelet agents, their effects are blunted. And as we've seen, angiotensin converting enzyme inhibitors are also blunted because of nicotinic action. Here you can see the acute effects of tobacco in all forms. The tobacco industry promotes surrogate uses of tobacco, non-smoked forms of tobacco, including nicotine replacement therapy, as a form of harm reduction. But as you can see in this very elegant study, which we carried out in India also, but this is from US, that whether it is smoked tobacco, oral snuff, chewed tobacco, or nicotine gum, which is given as part of nicotine replacement therapy. You can see the heart rate increases more or less similar in all four subsets. Systolic blood pressure is also similar in all four subsets. In fact, those who chew tobacco, it is slightly higher. Similarly, the diastolic blood pressure. Among tobacco users, the blood pressure shows more lability, and many of them, their measured blood pressure in clinical settings, in clinic, is found to be normal because blood pressure is measured under ideal circumstances. Patients are told that you should not have smoked, you should be at rest, should not have consumed caffeinated beverages. After tying blood pressure cuff, they are made to relax for 3 to 4 minutes, reassured. But once they smoke in real world, their blood pressure is elevated, and it is the temporal summation of all these hypertensive episodes which exposes them to chronic effects of hazardous effects of persistently elevated blood pressure. So they are just as bad, even if they are found to have normal blood pressure in clinical settings. So you can see nicotine also involves all the organ systems from top to bottom. It not only causes cerebrovascular disease, the occlusive stroke, it can also cause Alzheimer's. It causes a peculiar type of dementia, which is due to small repeated infarcts, lacunar infarcts called multi-infarct dementia. It can cause blindness. It can also result in a peculiar form of blindness, which is seen among poor social strata persons, tobacco amblyopia, which is due to spasm of retinal artery and also due to macular degeneration. It can cause involvement of atherosclerotic involvement of carotid arteries, which can result in embolization of platelets and cholesterol gravel, resulting in recurrent infarcts or transient ischemic attacks. We've already spoken in depth about myocardial involvement, cardiovascular involvement. I'll mention a little bit more about peripheral arterial disease, which are generally omitted from discussion when cardiovascular system is more. Tobacco use can result in dilatation of any artery, particularly aorta, and it can result in aneurysm of aorta, which can rupture and cause sudden death. It can also result in occlusive disease of peripheral arteries, resulting in gangrene. And also causes a peculiar type of occlusive disease called thromboangiitis obliterans or Burgess disease, where medium-sized arteries are involved peripherally in upper extremities and lower extremities, leading to digital gangrene. Sometimes it requires amputation of arms or legs also. It can also cause erectile dysfunction in men, resulting in impotence or increased infertility in females. So as you can see, the risk factor for this is from Global Burden of Disease, where you can see that tobacco is the leading cause of premature mortality. And along with that, high blood pressure, which it compounds, is the second leading cause of death. High body mass index, which we spoke in context of COVID-19, where almost 2/3 of the patients had one of the features of cardiometabolic syndrome, that is a third leading cause. Along with it, diet low in fruits and vegetables is not only a cause of premature mortality, but it also compromises immunity, which can make a person more vulnerable to infections, including COVID-19. Now, in the midst of any crisis lies an opportunity. There are encouraging signs that COVID-19 scare has facilitated cessation of tobacco. The reasons are very simple. Because whenever these health messages are given, these messages or attention which is required competes with many other attentions. You know, we have celebrities, we have sporting events, we have war going on somewhere, we have some very popular leader, I won't name them, in all parts of the world who enthrall their audiences with their rhetoric. But never before the global population at this scale has been so health conscious. There's only one agenda, health, because of this pandemic. And it is very encouraging to know that many tobacco cessation programs have been more successful during pandemic because of scare. Only thing is this message has to go out loud and clear, and it is not to be left to public health authorities, administrators, or medical profession. All of us should join in and spread the message far and wide that tobacco cessation can give protection against not only COVID-19 but due to COVID tobacco related morbidity and mortality. And the benefits are immediate. As you can see, I put it graphically that within 20 minutes blood pressure starts normalizing and pulse rate falls down. And within 24 hours risk of myocardial infarction starts going down, and within a year the risk of coronary artery disease is cut by 50%. And 5 to 15 years, the stroke is reduced to that someone who has become that of a never smoker. And within 15 years, coronary heart disease risk is the same as the person who has never smoked. So the benefits are immediate. And some medicines can also help to give up smoking. This message should be strengthened. And if it can be used in context of COVID-19 messages, it will be more effective. Other benefits of quitting tobacco are that within 48 hours, the smokers regain their ability to taste and smell normally, which is also compromised by the way in COVID-19 infection. In 2 weeks to 3 months, circulation improves. We've already discussed that. And in 9 months' time, the energy levels are more or less normal. The deconditioning which takes place, chronic sinus involvement, etc., are all the person recovers from all these things. And at 10 years, dying from lung cancer, which is the most dreaded message about tobacco, also drops to almost the same rate as that of a lifelong non-smoker. Now we come to home quarantine. There are many guidelines. I'll not go into the controversies. This is what is practiced in our country in India, that those who are asymptomatic or minimally symptomatic, they can be treated at home. Asymptomatic individuals are those who have tested positive either by RT-PCR or rapid antigen test in context of clinical illness. In context of this pandemic, they can be treated at home if they are minimally symptomatic or asymptomatic. Those who have mild shortness of breath, those who have facilities for home isolation, those who have some caregiver available to them 24/7, those who have good communications with hospital and have a properly ventilated dwelling unit, they can be treated at home. For how long? For about 10 days from onset of symptoms or 3 days after recovering from fever, whichever is later. There is no need to repeat test in home isolated patients, retest. Now, what is the treatment for mild cases who are being treated at home? Common sense measures, they should be at rest. Fever should be managed with antipyretics. Decongestants can be used for running nose. Warm water gargles and steam inhalation are very helpful. And if fever is not controlled with the ordinary crocin or paracetamol, other NSAIDs can be given. Other comorbidities should also be treated properly because, as we've seen, that people who have comorbidities like hypertension, diabetes, or are smokers, they are more vulnerable not only to contract infection but to develop severe clinical illness and complications or even higher fatality rates. What is not to be used at home, for which there is no evidence, are injection remdesivir, oral steroid, which have played havoc in India because people have treated uh, patients in home setting with oral steroids from day one for minimally symptomatic patients, and which has resulted in almost a mini epidemic of black fungus, the mucor. Also not indicated are ivermectin, plasma therapy, hydroxychloroquine, and azithromycin. Now, this is a very sensitive issue, but I think we should talk about it. We have a satellite pandemic in the form of infodemic, conspiracy theories, treatments which are not based in science, vaccine nationalism. I won't go into all those things, but one should avoid false information, should not follow outlandish claims. And as medical scientists, it is our duty to follow science based, evidence based medicine and not opinion or eminence based medicine. I just two, three examples I hear. As Winston Churchill said, that by the time truth puts on its pants, the lie has circulated many times around the globe. So, outlandish claims, etc., get wide press coverage, particularly if they come from a celebrity. As you can see, the Fox News in US also discouraged people from wearing masks, and people misquoted a CDC report, and of course, the then president also gave his views, which I need not repeat. Almost everyone knows about them. So, how to tackle epidemic, this epidemic of pandemic of misinformation? We should stick to science, read research from peer-reviewed journals, follow guidelines given by health authorities. Of course, they have necessarily changed as the evidence evolves. World Health Organization has revised its guidelines. So has CDC. So has our Ministry of Health and Family Welfare. And we should engage civil society, technology platforms, and journalists to propagate evidence-based guidelines and also promote health and well-being, because positive wellness and positive health is a protection in its own right. So exercise, balanced nutrition, good sleeping habits are, they go a long way in protecting from contracting infection, and also continue to practice social distancing, wearing of masks, maintaining hand and mouth hygiene, and practicing good ventilation in our office spaces, clinics, and households. So, in the midst of this contradictory advices, guidelines, conspiracy theories, how do we believe what is correct and what is not correct? Here, I would refer to Shakyamuni Buddha, who 2.5 millennia ago told a group of people, these were Kalamas, when he visited their village, they asked him that every now and then we have a wise man coming over here, gives us something new in the form of advice or dictate. Not only that, he criticizes all others who had come before him or all other religious leaders or pundits and wise men, criticizing them for their lack of knowledge or accusing them of spreading false information. And we get so confused. So, what to do? He gave them this advice, which is part of Pali canon of Mahayana Buddhism. It's called Kalama Sutta, and I'll read it out. He told them, do not believe in anything simply because you've heard it. Do not believe in traditions because they've been handed down for many generations. Do not believe in anything because it is spoken and rumored by many. Tyranny of majority, as I would say. Do not believe in anything simply because it is found written in your religious books. We all know evidence of yesteryears is not evidence based today. Do not believe in anything merely on the authority of your teachers and elders. Sometimes there are Nobel laureates who pontificate outside the area of their expertise. So we have to scrutinize everything, and it should be through the evidence which is current and scientific. And he told them that after observation and analysis, when you find anything that agrees with reason and is conducive to the good and benefit of one and all, then accept it, and very important, and live up to it. So with this, I come to end of my talk. Thank you for your attention. We should stay calm, safe in the midst of turmoil of this pandemic. Thank you very much. Stop share. Okay.
Thank you so much, Dr. Kashyap. We will now be taking questions. So I have a list of questions that people had submitted in the registration forms. So I will ask that. What are the considerations for cardiomyopathy and heart failure in COVID-19? How should patients with cardiovascular diseases manage potential workspace exposure to COVID-19?
Can you repeat this question? I've just removed this earphone which was troubling me. So now hearing is more important. So I'll hear better from
Okay, yeah,
computer audio.
of course. The question is, what are the considerations for cardiomyopathy and heart failure in COVID-19? How should patients with cardiovascular conditions manage potential workplace exposure to COVID-19?
How should people with cardiovascular condition be managed at?
How should people with cardiovascular conditions manage workplace exposure to COVID-19?
First of all, they should follow all those precautions which a person without cardiovascular condition would follow. That would mean avoiding or giving up tobacco, practicing social distancing, remaining masked, maintaining hand mouth hygiene, and also taking vaccination, because vaccine hesitancy is seen across the board. Okay. After having followed these, those who have cardiovascular condition, I would come to the commonest condition first, hypertension. It should be well controlled. There were rumors that a class of medicines called angiotensin converting enzyme inhibitors should not be used. That controversy has been laid to rest. All societies have said that they do not interfere with, they do not make one more susceptible to COVID-19 infection. So well-controlled hypertension. Those who have cardiomyopathy and all other conditions, arrhythmias, they should continue taking their medicines. Most important, not only people with cardiovascular conditions, even others should not take treatment which are not evidence-based and expose them to cardiovascular morbidity and even mortality. They are unnecessary use of steroids, azithromycin, chloroquine, hydroxychloroquine. Particularly when azithromycin or chloroquine are taken together, they increase what is called QT interval on surface ECG, which makes people vulnerable to a dangerous type of arrhythmia called, graphically described by a French term, torsade de pointes. It's like screw coiling around, so torsades. Polymorphic ventricular tachycardia, which can result in sudden death. So these are the precautions which people who have cardiovascular conditions should take. They should not be more vulnerable if they are properly treated or controlled, if they practice this. With the exception of subset of people who have metabolic syndrome or hypertension, which is a metabolic disease. Hypertension is not simply raised blood pressure. So they are more vulnerable and they should be extra cautious.
Thank you so much for this insightful answer. The next question is, what are the effects on people with heart surgeries or transplants? And what are the primary treatment protocols?
As I described, that those who've undergone bypass surgery or percutaneous interventions, they should continue taking their medicines. They would benefit far more by practicing well-being and health practice, and I'll elaborate on that. They should not smoke, number one, under any kind. There are people who continue to smoke, they should not smoke. They should carry out regular exercises because that in and of itself is protective. Thirdly, they should take all their medicines regularly. And features of metabolic syndrome are usually clustered. That's why this eponym is used metabolic syndrome. So if they have tendency to have hyperglycemia or have raised glycosylated hemoglobin, they should take proper care of their nutrition, which includes increased amounts of green leafy vegetables, fruits, and other vegetables. And they should not consume processed carbohydrates, which includes inordinate amounts of white flour, which could be wheat or polished rice, or products made from these, and sugar in all its forms. They should avoid that.
Thank you so much. Our next question is that in times like these, how can research play a crucial role in safeguarding the future?
Okay, that is very important. Now, never before has so many papers published on one disease with such speed. It has some good aspects. The virus was identified within a week or 10 days after it came to notice that it's causing pneumonia on a very large scale. WHO declared pandemic within 2 months. Vaccines have been developed very fast, but so have misinformation, pseudoscience journals have come up, and poorly designed studies claiming benefit of many medicines, which of course were negated later, but that sometimes the damage is already done. If you have rampant use of drugs like ivermectin, steroids, inappropriate use, hydroxychloroquine, the damage is already done by the time it comes out that they are of use. So properly designed trials are very important. And also, anything which is published in, since most of the audience here are students, I would recommend a book. Its title is self-explanatory, How to Study a Study and How to Test a Test. So not all studies which claim some benefit, if you read the fine print or understand statistical analysis, would support the message which is given in catchy title of the paper. Sometimes the coverage in the lay press is even more outlandish. Such and such drug cuts mortality by half. They will always talk about relative reduction, not absolute reduction. For instance, if some disease prevalence is 2 per 100,000 patients, and some drug brings it to 1 in 100,000 patients, it could be just a chance finding. It is not statistically significant. But the lay press would claim 50% reduction in mortality because of this medicine. And then you have to give it to 100,000 numbers needed to treat. Even if that statistical analysis is correct, which it obviously is not, it doesn't have the statistical power to make that statement. Still, you would need treatment at such a large scale, and then not only the economic cost, but the health burden of unnecessary side effects would be quite a bit.
Thank you so much for that answer. Can patients, what are the chances of development of a thromboembolism after the vaccine? And can patients on blood thinners develop a thromboembolism?
This came up in Europe, and about 13, 14 countries had stopped vaccination with AstraZeneca vaccine. Now, it could be a chance development because later when the data was pooled in, it was found that clotting disorders were not more among vaccinated persons. So that controversy has been laid to rest. As that was the first part, that thromboembolism is not higher among those who are vaccinated. Second is, should the vaccine be given to those who are already on blood thinners? Answer is yes. First of all, just because they are on blood thinner, the jab with a small needle doesn't result in local hematoma, and there are no systemic clotting disorders because of this vaccine or the trauma of this injection. So they should continue. Not only they should continue, there is no hazard of their consumption among vaccinated patients. On the contrary, if patients stop those medicines because they're more scared of corona or COVID-19, so some patients may say, because of this scare, that since these medicines are blood thinners, I should stop them. Stopping those medicines is more hazardous. So they should not stop.
Thank you so much. We will just take one more question. Between people with heart problems and COVID vaccine, is there any contraindications?
Among heart patients, no. As I said, people who have heart disease, people who have diabetes, those who are obese, hypertensive, they're more vulnerable to COVID-19. In fact, they were preferentially vaccinated all over the world, not in our country too. Many patients came to me for this certificate that I have heart disease, so give me this certificate. I'm not yet 60. Those days only 60 plus people were getting vaccinated, so they were given vaccine. So there's case for getting vaccinated is stronger among them, those who have heart disease.
Thank you so much for the session and for answering any questions. We have another one. Can COVID-19 vaccines lead to myocarditis?
This was in the news day for yesterday, that some patients have developed, some children have developed myocarditis. Anything which can incite immunological reaction can result in myocarditis. Okay, but on a population level, the protection offered by vaccines is far more than few odd cases of myocarditis that might occur. So it can occur. It has been reported with all the vaccines, myocarditis. After all, myocarditis is inflammation of the heart. So that can. But that is not a reason to not go for vaccination. It is like saying that Latour had an earthquake. Should I be driving through Latour again because it had an earthquake? Answer is no. These are very rare occurrences. They're random occurrences, and because of them, you must realize that vaccine not only protects an individual, it protects the population. So few odd events there are not good enough reason to withhold vaccination, both for the entire population and for the individuals.
Thank you so much for that answer. That's all from me. It was an honor to have you here today. I will now pass this along to Anushka for closing.
As Bruce Wilkinson said, a moment of gratitude makes a difference in your attitude. It is with great pleasure that I now present to you the vote of thanks for this webinar's proceedings. Hello, everyone. I am Dr. Anushka Reddy Murray, and I am the editor-in-chief of Lexicon, the online medical magazine. Firstly, I'd like to thank our guest speaker, Professor Dr. Shekhar Kashyap, who, despite his busy schedule, graced us this evening with an incredibly enlightening presentation where we were extremely grateful to learn about COVID-19, serious complications of it, and at-home care. I would also like to extend a heartfelt gratitude to the live study group's lead, Samantha Sindhu, and by extension, all the leads from both organizations, SAC and Lexicon, for their major contribution in making this event possible. Special thank you to our co-facilitators for their endless support. Last but not the least, ladies and gentlemen, thank you to each and every one of you that has joined us tonight and helped us make this event a success. And we look forward to your continued support. A gentle reminder to everyone to fill out the feedback forms which were sent to you along with your invitations to your email. They were also sent in the messages in Zoom and YouTube chats a few minutes ago. Remember that only those who fill out these forms will be given their certificates, and the certificates will reach you within 2 weeks of time. Finally, for those of you who are interested in joining SAC and by extension the LSG, please indicate by doing so in the respective sections in the feedback form. Thank you, everyone, and good night.
Thank you. Good night.
Thank you, sir.